Good evening, everybody. I'm Becky Slang, an Associate Dean for Academic Administration here at the College of Health Sciences. It's my pleasure to introduce our speaker, Dr. Stacy Anderson. Board certified in nephrology and internal medicine, Dr. Anderson is the Assistant Director of Nephrology and Hypertension for the Geisinger Health System. She directs the American Heart Association Certified Comprehensive Hypertension Center at Geisinger Lewistown Hospital. She specializes in system-based quality improvement and patient-centered care for patients with hypertension or chronic kidney disease, including patients needing dialysis. A native of central Pennsylvania, Dr. Anderson completed her residency in internal medicine at the Penn State Hershey Medical Center and her nephrology fellowship at the University of Pittsburgh. Today, Dr. Anderson will be speaking about takeaways from the 2025 American Heart Association hypertension guidelines and offering practical guidance on how to apply them. Please join me in welcoming Dr. Anderson.
Thank you. And thank you so much to the School of Medicine for the invitation to come speak, and to Anne and Becky for helping to organize this event. I'm really grateful for the chance. All right, so the title of the talk tonight is Our Blood Pressure, Our Health, Hypertension Care for a Stronger Future. So this is not original material that I produced. This was very much a team effort, and I have one of my partners here in the front row, Dr. Shang, who helped with the materials for generating this production. Another of our colleagues will be joining us hopefully a little later. So the three of us really collaborated on this presentation, and we don't have any relevant disclosures for tonight's talk. All right, so the objectives for tonight, we're going to describe the stages of blood pressure control according to the 2025 guidelines that were released last August from the American Heart Association and American College of Cardiology. We're going to talk about the blood pressure target for the best risk reduction per these guidelines, and we're going to identify which patients need immediate intervention for better control of their blood pressure. Finally, we're going to list the concepts behind each letter of MAP in MAP-BP, and talk about how the concepts behind MAP-BP apply in patient care and help us bring these guidelines into reality. All right, so almost half of American adults have blood pressure, have high blood pressure, and most of them don't know they have it. Okay? And if you drill down and take a look at adults in this country with uncontrolled blood pressure, it turns out that over 3/4, where's my laser pointer? Over 3/4, right, have uncontrolled blood pressure. So vast numbers of people in this country with uncontrolled blood pressure, and vast numbers of people in this country with the diagnosis of high blood pressure. Why do we care if our blood pressure is uncontrolled? Well, we know that the long-term outcomes associated with uncontrolled hypertension or uncontrolled blood pressure include dementia, stroke, heart attacks, heart failure, and chronic kidney disease, including kidney disease severe enough to need dialysis, right? Those are outcomes nobody wants to have, right, for themselves or their families. So we don't want to have uncontrolled blood pressure because we want to prevent these end results. Uncontrolled blood pressure has high costs. It was the primary or contributing cause of death to over 660,000 deaths in this country in 2023. People with uncontrolled blood pressure have more than $2,700 annual healthcare costs compared to those without that diagnosis. And the total costs to the healthcare system, because so many people have this diagnosis, the costs are huge, right? So there's over 219 or an estimated $219 billion of cost to the healthcare system because of blood pressure diagnoses from 2019, okay? There's been work underway for a long time now trying to get better at addressing blood pressure control. We've learned a lot. We know that, for instance, that if patients measure their own blood pressure, if they adopt self-measured blood pressures, providers get more data and better data, hopefully, to use as they work to get better blood pressure control. If we adopt self-measured blood pressure programs, we could reduce heart attacks by nearly 5% and generate an average of $7,800 of healthcare savings per patient over 20 years. Okay, so that sounds like small stuff, but multiply that by the number of patients who have uncontrolled blood pressure, and it's big savings. We also know that team-based care in taking care of patients with hypertension, particularly involving advanced practice providers or pharmacists, can help with getting blood pressure under control faster. We know it can prevent up to 91,000 heart attacks, 139,000 strokes, and over 115,000 cardiac deaths over 5 years. This would also save the Medicare system over $900 million over 5 years. Okay. So team-based approach, it's all about team-based approach and different ways to engage this problem that's not new. So in August of 2025, the American Heart Association and the American College of Cardiology released new blood pressure guidelines. But I submit to you, it's a little bit of new and a little bit of old, okay? And that's a good thing, like most good things, right? So here are the blood pressure categories, and they're not really changed from 2017, okay? So normal blood pressure, less than 120/80. Elevated blood pressure is defined as systolic blood pressures, that's the top number in the 120s, and a diastolic, which is the bottom number, under 80. Stage 1 hypertension is top number in the 130s, bottom number in the 80s, either or. Stage 2 hypertension, top number in the 140s, bottom number in the 90s. And then severe hypertension greater than 180 over 120. All right, so now we're going to practice. And we have that, I'm not going to toss that beanball thing around just yet. But it's important because I see patients every day. We're checking blood pressure every day. Lots of them come to me with a blood pressure of 130/70. Doc, I'm acing it. I got this. I'm doing well, right? But in fact, if you look at the guidelines, 130 over, what did I say? 130/70, right? Stage 1 hypertension. Okay. So I get to be the one to say, to rain on the parade, right? Say you're doing great, and there's more to do, right? Another one, 126/76. Doc, I'm acing it. I got this, right? Everything's good. Why do I have to do it? What do we do? Well, could we do better? You bet. We could. Not only could we should do better. I'm not trying to convince you of that tonight. Okay, elevated blood pressure, 126/76. Next one, 142/80. Survey says stage 2, absolutely. Stage 2 hypertension, okay? 126/82, that one looks pretty good, right? Oh, we have work to do, right? That diastolic blood pressure meets criteria. I don't know if I'm getting this thing. Meets criteria for stage 1 hypertension. So, all right. So, what is the blood pressure target that best lowers your risk of developing chronic diseases of the heart, the brain, the kidneys? The best blood pressure target. Less than 120/80. Less than 120/80. Okay, so if you're in clinic and you're not running that on average for blood pressure, then there's probably more that could be done to lower your risk or the risk of your loved one. Okay, I do have an asterisk there. okay? And that's for pregnant women. So that's one exception. Pregnant women, we tend to allow blood pressures that are slightly higher. We target under 140/90 for pregnant women at this point. All right, so those blood pressure control categories, those stages of hypertension, that's not new. That's no news there, okay? But what's new about 2025 is action items, trying to push the envelope to get providers and patients onto this, to address this problem sooner and more consistently, okay? How do we do that? We do that with early treatment, a personalized approach, and focus on prevention. We're trying to prevent dementia, we're trying to prevent kidney disease, heart failure, heart attack, stroke. There's data emerging also that controlled blood pressure can help lower your risk of developing diabetes as well. We do that by using early treatment. So we work hard every day to measure blood pressure accurately, and we don't sit on elevated pressures, we act, okay? And we work at developing a personalized approach for patients. So we're trying to engage with patients to help them understand their specific level of risk by using a new and improved risk calculator, and by engaging them to do accurately performed self-measured blood pressure, engaging patients to think about what lifestyle changes would apply well in their lives, in their world, not fix all of it, but what's a small thing we could do today that reflects sort of where the patient is and who the patient is. All right. Yeah, just in case you forgot, right? 3/4 of the people in this country, more than that, 3/4 of the people in this country have uncontrolled blood pressure if they carry this diagnosis of hypertension. It cannot be overlooked. So MAP-BP is a nationwide program sponsored by the American Medical Association. And I don't know that it was framed this way. It actually predates the blood pressure guidelines, but all this work is in the air, right? And so MAP-BP is a nationwide program designed to help health systems address uncontrolled blood pressure sooner, better, longer, more consistently, more effectively. So it's a script, if you will, for implementing these guidelines. All right, what do we know about uncontrolled blood pressure? Science tells us the way that we measure blood pressure in clinic is prone to error. We don't do a very good job. We have work to do a better job at measuring blood pressure with less error and less variability, okay? We also have work to do because we know that the way we treat blood pressure is not adequate. It's not effective. We can do better at treating uncontrolled blood pressure. And finally, we often miss opportunities to engage patients in their care, to educate them about what's going on with their health, and to help give reasons why they should invest in this path of caring for their blood pressure and caring for their health in the short term and the long term. So MAP is an acronym. It stands for Measure Accurately, Act Rapidly, and Partner with Patients, right? It's a way to respond to the deficits that science tells us are inherent in our current state of taking care of patients with high blood pressure. 27. So you don't have to remember this number. The point is, it's big, okay? It's a big red number. And the reason it's a big red number is there's just a list of 27 different variables that are in play each and every time we measure blood pressure in the clinic, okay? So if you have 27 different variables at play, it's hard to know that you're getting consistent high quality measurements. And we need that because we need to put people into risk categories. So we want to minimize all these variables best we can. We're never going to get rid of all of them. What do we need to do to get an accurate blood pressure reading? We need to ensure that the cuff fits. We need to have it positioned properly on the arm. We need to have the arm properly positioned, supported and at heart level. We need to have the patient sitting in a chair with a back to it. So their back is supported, their feet are flat on the floor. We need to ensure that the blood pressure is checked on bare skin. And probably most important, all of these is staying silent and still. So taking a few minutes of quiet so that you can get a proper blood pressure check. That's difficult. That's a big ask in a busy clinic, right? Nurses are busy, providers are busy, patients want to get through, right? But we need to take the time, set the stage, and get a good reading. All right, so here's an example. Right? What's going on? What could this patient and this team take away for places that they could improve, right? How about this one here? Talking, right? Distracted, certainly not silent and still, right? How about here? Yeah, feet are not there. How about here? Legs are crossed, right? Feet are not flat on the floor. Do you see any back support here? No, no. I had a patient who sent me a whole bunch of blood pressure readings once. They were all over the place. Turns out he was sort of hovering on the side of his bed, like engaging his core, feet off the floor. Right? So it was a great opportunity to talk about what, how to do things differently. How about this arm position? Too low, not heart level. How about this sleeve here? Exactly. We need bare skin to get a good reading. And this might be a little hard to see, but this cuff isn't suitably positioned. That's the takeaway point. So lots of things, lots of opportunities here. Every day, every patient. Next slide. You should be able to click them. All right. So checking blood pressure is a process, whether you're doing it in clinic or at home. And every time we're checking it in clinic, it's an opportunity to educate and engage our patients. Okay, so we want to make sure they haven't just come from a big heavy workout or a big heavy meal. We want to make sure they're avoiding stimulants like nicotine and caffeine. We want to make sure their bladders are empty. All that's before we get, and we want to make sure they're taking their blood pressure medications properly, just the way they, per their usual routine. Okay, we also, that's all before they get into the room. And then when we get into the room, we have all those considerations of positioning that I stepped through with you, plus very important, silence and stillness. Use an automatic validated blood pressure cuff, all right? This is another important step in measuring accurately, okay? An automatic cuff, well, we'll talk about that in a second. Like here, why do we care about an automatic cuff, right? Used to be the standard of care, right? You check on an automated cuff, and then if that's not right, what does the team do? What's the first thing they do? They grab a manual cuff and check, right? Used to be manual was gold standard. That's old thinking, okay? Now we use automated devices. Why? Because we're trying to get rid of those 27 variables. We're trying to tone that down, okay? Automated devices require less frequent checks to make sure that they're still accurate. Automated cuffs reduce human error, right? Differences in people's ability to hear, biases, unconscious biases, right? To try to make the second blood pressure better. And it allows for the focus for the team or the patient, actually both, to focus on proper positioning. Because there's a lot to think about just in positioning the patient. All right. What is a validated blood pressure device? What do I mean by that? I mean a device that's accurate for clinical use, right? So it's perfectly legal for me to sell you a blood pressure device that may or may not be accurate. A self-measured blood pressure device may or may not be accurate, perfectly legal, okay? So we need to work against that. We need to account for that. And how do we do that? ValidateBP.org is a website maintained by a consortium of clinicians and academics of blood pressure devices that have been shown to be accurate. Okay, so you can show patients, you can recommend certain certain blood pressure cuffs off this website, or you can invite patients to go to the website and look for home blood pressure devices. It's a subcategory there, and they can find one that works for them. All right, so we've talked about measuring accurately, right? Let's talk about acting rapidly. So we want effective, responsive treatment for every patient, and we want it every time. We do not let people leave clinic with uncontrolled blood pressure without a plan. There has to be something you're doing to address that, okay? So one of the best ways to do it is to use combination therapy. What do I mean by that? I mean blood pressure medications from more than one class. 2 different kinds of blood pressure medicine, and ideally 2 different kinds of blood pressure medicine in 1 pill, because that's just easier. Okay, combination therapy has 3 times the effect of blood pressure lowering as increasing the dose in the same blood pressure class. So if I introduce 2 blood pressure medications, if you think of it, I'm hitting it from 2 different angles. And so the blood pressure control is more effective, rather than using only 1 and maxing up the dose. That's not as effective. And this is just a chart showing the risk reduction, which is anything on this side of the screen, it shows reduced risk, okay? And so you can see monotherapy has reduced risk of any cardiovascular event, including heart failure, cerebrovascular disease, ischemic heart disease, and it lowers the risk of death significantly also, okay? Sometimes people, and I'm in the front row on this, you could be reluctant to introduce combination therapies because you're concerned that the patient might have adverse effects. They might, the blood pressure might bottom out, or their kidney function might get worse, or they might not tolerate all this. But the research shows that there's no difference in stopping medications with combination therapy versus monotherapy. So the rate of adverse events is there's no difference. It's okay, it's safe. All right, so we talked about combination therapy and preferably single pill combinations. Another way to act rapidly is to use a medication treatment protocol, meaning a script for blood pressure control. All right, so this is an example of the Geisinger hypertension treatment algorithm. And the intent today is not to memorize the script, but to show you that these scripts are powerful, because now Dr. Chang doesn't have to see his patient every 6 weeks to work on blood pressure. Dr. Chang can partner with an advanced practice provider or with a pharmacist who has a roadmap for what to do and how to move forward on blood pressure control. So having a script, having a treatment protocol lets you move ahead more quickly and more effectively on getting tighter control. All right, so we talked about measuring accurately, we talked about acting rapidly, and now we're going to talk about ways to partner with patients. We mentioned self-measured blood pressure, right? And I'm repeating these figures showing that heart attacks could be reduced by nearly 5% and strokes by nearly 4% using self-measured blood pressure monitoring, according to research, because it's a way of engaging patients, okay? And team-based care, including a pharmacist, has been shown to dramatically reduce the risk of stroke, heart attack, and death. Okay, so why wouldn't you use this? Why wouldn't you use a team-based approach to have all hands on deck and address this problem? We also want to get to know our patients and offer personalized lifestyle changes, right? Not just the blanket rote, move more, eat less, don't use salt, right? It's more effective if you know your patient and you know, like, hey, you're a hunter. Okay, well, how can we get you ready for hunting season? I practice in rural Pennsylvania, so that's a very big deal. Or get you ready for the county fair so that you're able to walk the grounds and enjoy it. And then we use the prevent risk calculator, or we want to use a prevent risk calculator because, again, that gives more personalized sense of what the cardiovascular risks are. Let's talk more about the calculator and compare it to the old guidelines. So the 2017 ASCVD risk score gives you the 10-year risk of having a heart attack or stroke, okay? But if I have a 35-year-old patient or a 45-year-old patient, right? Unfortunately, some of them do have a high 10-year risk of heart attack or stroke, but many don't. And so I'm missing an opportunity to engage with them with that relatively short time horizon. The new prevent risk guidelines, the prevent risk score, has a 30-year time horizon in addition to the 10-year. So now I can talk to patients younger, earlier in their life, earlier in the disease course, and hopefully with that broader time horizon, we can start treatment sooner and more effectively, okay? The old risk score talked about the risk only of heart attack and stroke. The new one addresses heart attack, stroke, or heart failure, or all three. So, and maybe by 2030, we'll have kidney disease in there, but we'll see. But already we've broadened the scope of the conditions for which the patient's at risk. So you can speak more meaningfully about health conditions that that patient might face if they don't address the blood pressure. And the prevent risk score takes into account many more variables. You can see almost twice as many compared to the 2017 risk score that was recommended. And it includes more effective assessments of social determinants of health by including the zip code as an option. It includes renal function status, including albuminuria, so protein being spilled in the urine, which is a very important marker of endothelial dysfunction that's often overlooked in patient care, but it's hugely valuable in thinking about kidney risk, but also overall cardiovascular risk. And it includes things like not just whether you have diabetes or not, but how well controlled is your diabetes. So it allows you to have more individualized risk assessment, and it allows you to talk about cardiovascular disease risk earlier in the life cycle. And so those two things together hopefully will be a kickstart to getting involved at controlling the blood pressure sooner and having it be a lifelong focus. All right, so I've tried to convince you tonight that poorly controlled blood pressure leads to all kinds of outcomes, that blood pressure control predicts how you're going to do from a cardiovascular standpoint long term. So if your blood pressure is uncontrolled, you're setting yourself up for all kinds of grief from stroke, dementia, heart attack, heart failure, kidney disease, and potentially diabetes. Nobody wants to go there. Okay, I'm going to shift gears right now and talk about some hypertension cases. And I want to send a shout out to Dr. Bali, who was instrumental in putting these cases together. All right, case number one, the salt shaker. 58-year-old gentleman, average blood pressure 138/86. He's a home cook, loves to cook, pours on the salt when cooking, right? Because that's what makes things taste good, right? Not currently on any medication. And as far as we know, this patient has healthy kidneys. All right. So how can we, well, first of all, what do you guys think? What do you think about this blood pressure average? Not good. Too high, right? Lots of times this guy, it's under 140/90, right? That's a goal in a lot of, by a lot of quality measures in clinics. So it meets the goal, but it's not, but it doesn't meet the right goal, which is what's best for his long-term cardiovascular health. So stage 1 hypertension, actually. So, and we want to figure out how can we make changes in his blood pressure? What lifestyle changes can we offer this patient? How can we engage with him? So we could come up with a simple food plan. What are we doing? We're going to take the sodium out, even though he loves it, and we're going to put potassium in. And by making those switches, we're going to help him develop a healthier diet, which will be more likely to control his blood pressure. This is the DASH diet, dietary approaches to stop hypertension, which essentially favors more plant-based foods, higher potassium intake, and less sodium. So how could we tailor that for this patient? We could suggest specific high potassium foods that he likes or can access readily. For example, here you might recommend beans or spinach or bananas. We can recommend that he switch sodium chloride salt to potassium chloride salts, which will increase potassium intake and lower sodium intake and doesn't affect his home cooking, right? Or at least not, hopefully not too adversely. And we want to make sure we talk to him about the fact that we've verified that his kidneys are okay before we start dumping potassium, right? That would be a bad plan for somebody with advanced kidney disease. We want to make sure that he's on medications. He's actually not taking any medications, but again, you want to, as a provider or as a patient, sort of have a pause to make sure, have I checked the kidneys? Have I thought about the medications? Are there things here that could be impacted by adding more potassium to the diet? So we are recommending lifestyle measures that have the potential to drop his blood pressure by 5 to 7 points, okay? That's not going to get him in the controlled range probably, but that's going to be a big step on the path to getting him controlled, and we did it without medication, okay? And it's engaged him. Small changes where he lives, because he's a big food guy, right? Small changes make a big difference, but they're tailored to the patient. Next one, an in-office spike. So 2017 scenario. Here's a 48-year-old lady who does not have a formal diagnosis of hypertension. She comes to your office, her blood pressure is elevated, 148/92. You notice that at the last clinic visit, it was also elevated. And she tells you, you know, tick-tock, I got to get out of here. I'm late for work. The kids are home from school because of the snow, right? I'm stressed. I'm anxious, all right? So the 2017 approach would be potentially diagnose this patient with hypertension, stage 2, right? Because the stages are still the same. And if you have stage 2 hypertension, you can go ahead and start 2 blood pressure medicines. Boom. Now she's gone from 0 medicines to 2. Okay. The 2025 approach is different. We're not going to reach for the medications right out the gate. Instead, we're going to talk about accurate blood pressure measurements. We're going to talk about why, if you're jittery and anxious, that might not be the best time to measure your blood pressure. And how can we take steps to prepare ourselves to get good, accurate measurements, to get a bunch of measurements, kind of like you would for blood sugars for diabetes, right? You want a bunch of measurements to take a look, figure out what's the ballpark where this patient lives. So we're going to partner with this patient. We're going to show her validatebp.org or just get her a device from that website. And then we're going to have her do a self-measured log. And what do you know? When you educate her and engage her, it turns out her home blood pressure is 126/78. She does have an in-office spike, right? So 2 different approaches lead to 2 different diagnoses here, all right? So 2017, you're saying, hey, this lady has stage 2 hypertension, you're hitting her with medications, which would be concerning that she might bottom out and have symptoms and not feel like partnering with you on your next medication recommendation, right? Because you just bottomed out her blood pressures. On the other hand, in 2025, we've partnered with the patient. We've educated her about blood pressure. We've given her tools to check it. And we have together learned that, in fact, she doesn't have stage 2 hypertension. She has white coat hypertension, meaning she's at risk to develop hypertension. She still has elevated blood pressure. But with intensive lifestyle measures, she may be able to avoid medication. So, and we're going to watch her closely to make sure that that degree of blood pressure she's at risk for her blood pressure to worsen because of the white coat diagnosis. So we certainly need to watch her closely. So two different approaches, two different eras, if you will. All right, another scenario, metabolic risk. So here's a 50-year-old with stage 1 obesity. So the BMI cutoff for defining somebody as obese is a BMI over 30, all right? But, you know, BMI of 32 is not bad as far as BMIs go for obesity, right? And this person has stage 1 hypertension. So in 2017, we would have given this patient medications right out the gate, 2 different classes, a thiazide diuretic and an ACE inhibitor. And then we would have talked about lifestyle, right? Move more, eat less, don't use salt. Okay, but the medications come first. And it's kind of a one-size-fits-all approach. Okay. In 2025, we're looking a little more at the whole person, at everything going on with this patient, not just a myopic focus on blood pressure, right? And we're thinking about, hey, we could introduce, we're going to focus on lifestyle and we're going to focus on medication, but part of that medication discussion is going to be talking about addressing obesity. And the 2025 hypertension recommendations suggest considering therapy to help with weight loss, okay, like a GLP-1. So you address obesity not just as a lifestyle issue, but directly with medication, along with medication and lifestyle to help reduce blood pressure. Here's another scenario, a quote unquote resistant patient. And by resistant, what I mean is this patient has resistant hypertension. Not that she's resisting care, but she needs 3 medications. She's already on 3 different classes of blood pressure medicine, and nonetheless, her blood pressure is uncontrolled. Okay, that's the definition of resistant hypertension. Somebody with complex, challenging to manage blood pressure, and she's not controlled. And we notice here that her potassium is normal. The reason it matters that her serum potassium is normal is it's sort of a textbook board question or you know, a question for trainees studying medicine. A patient like this, you would be prompted to think about primary hyperaldosteronism. So you'd be prompted to think about an endocrine disorder driving the blood pressure problem. And I say prompted, it would not be something you would necessarily pursue according to the 2017 guidelines, because classically, the textbook example for a patient with hyperaldosteronism is someone with low potassium and resistant hypertension. This patient has normal potassium. But now in 2025, any patient with resistant hypertension should be screened for hyperaldosteronism. This is a strongly supported recommendation because we don't diagnose primary aldosteronism as frequently as we probably should as clinicians. And it makes a big difference for the patient if we have the appropriate diagnosis, a more refined diagnosis that is reflects this particular patient, because it gives us, the treatment is different. So in 2025, anyone with resistant hypertension should be screened for primary aldosteronism, even if their potassium is normal. Even if they don't look like the textbook, you should still be thinking about that. All right, here's another scenario, clinical inertia. 55-year-old male with hypertension, currently on 5 milligrams daily amlodipine, blood pressure is 138/88 at their office visit. Coprosthetic? No, uncontrolled. Stage 1 hypertension, okay? So patients saying, doc, I feel good. I don't need to change my routine. I got this amlodipine. I'll be good. I'll lose weight, whatever. Okay. So in 2017, we might have let that patient go out the door with that plan, that the blood pressure is, you know, it's close to 130/80. It's not really there, but it's close. And we'll tell them to make some lifestyle measures like limiting sodium intake, and then we will follow up in 6 months. Okay. If we do that, we're doing a disservice to the patient because we're subjecting him to half a year of excess risk. for all the cardiovascular events that he didn't need to have instead of intervening early. Okay, so the 2025 approach would be to say, actually, that blood pressure is not okay. And I can give you therapy. I can give you better therapy, still one pill. So a little bargaining, right? So we could use a combination pill, continuing his amlodipine, but introducing benazepril as well in a combination pill, which is more effective, 2 different classes of medications. We can have him do home blood pressure monitoring, self-measured blood pressure, and we'll call in reinforcements. We'll get the pharmacist to partner with this patient and follow up in 6 weeks to see if that pill is enough to get the blood pressure down. And if it's not, we'll keep acting. We're going to keep circling back until that patient is at goal. Aging brain. All right, so this gentleman, 68 years young, with a blood pressure of 134/82, so not the best control. And he's worried about his memory because his father developed vascular dementia. So according to the 2017 guidelines, we would certainly want to get this patient's blood pressure down, but it was really a focus on heart health that was driving that target. And so, the dementia element, this patient's family history, this concern that he brought to you front and center doesn't really apply so much in the 2017 guidelines. The 2025 guidelines are broader and more personalized to him. So it is level 1, so strongest class 1 evidence, strongest possible recommendation based on the scientific knowledge that getting that blood pressure under 130 systolic will help his cognitive status long-term. And it's one of the things, we can't change his genetics, but we can change the blood pressure. And that's one of the things we can do to meet his stated concern of doing all we can to prevent vascular dementia. All right, so what I'm trying to emphasize here today is for every 10 millimeters of mercury above goal systolic, the risk of a major cardiovascular event increases significantly. It's not okay to sit and watch somebody with uncontrolled blood pressure. Who's the person who needs intervention? Every patient, something, some kind of discussion, some kind of education, some kind of intervention and plan. Waiting 6 months to see how it goes is not acceptable. So just to recap, we've gone over all the categories for blood pressure control. That was one of the goals. The systolic blood pressure that best lowers the risk of chronic disease, whether it's your brain, your heart, your kidneys, is less than 120/80. And that's for all comers except pregnant women. And MAP is an acronym for a way to implement these guidelines by measuring accurately, acting rapidly, and partnering with patients. Thank you very much. So we're going to have questions now, and there's this, I need some help. I'm wondering if there are any people here who could help.
Could you help?
There's this bouncy microphone,
Yeah.
and I think it needs a special
Question, they can raise
a
their hand,
box.
you can give them a microphone.
There's a
Okay.
question.
And I have my
Wait.
partners here to help with questions as well.
I'm diabetic for like 10 years. I take Jardian, I take Congentin, and I take, what's the other drink? I take another high pressure drug, Sartan.
That's for your blood pressure.
Yeah, Sartan, Congentin, and Jardian, and Topola. So I take a lot of drugs. So is that too many?
It depends, right? What does your self-measured blood
Well,
pressure
my
log
kidney
say?
function is 50. So he's worried about the kidneys for the Jardians for the kidneys. The other stuff is the pressure to get it down.
Right.
So what else has to take? Anything else? Or just stop taking pills?
Well, let's start out. I'm not here to offer specific medical advice for
I'm
specific.
taking a lot of pills. I'm working.
Taking a lot of pills. Yeah, what's up with that? But the answer is, even for kidney health, I'm trying to get your blood pressure controlled. I'm trying to make sure you're not spilling protein in the urine, right? As a
Right.
diabetic whose kidney function's already at 50,
Right.
right? And I'm trying to keep those blood tests, the kidney function good. We're trying to juggle all three of those and keep them good for your kidney health, right?
Right.
And a key one in there is blood pressure. So are you taking too many pills? I don't know. It depends on how those three look together. And it depends on what your self-measured blood pressures look like and how you're feeling.
Well, diet's important, and I feel eat the wrong diet, I get lightheaded.
Yeah,
So diet is very important.
100%.
So, and exercise is important.
100%.
So you're doing the right things, you can have a little longer stretch in life.
Yeah, absolutely.
But I'm worried about taking the 3 pills and plus Fjordanian. Is that too much for me or that's normal?
So it is guideline recommended. Like if you're not at goal, I am bringing you more pills.
Okay.
I'll give you 8 pills if I have to. I'll give you 28. And I do. I mean, not because I like to, but because some patients need that.
Because before I was on the pills, I was getting high numbers like 140, 150. Now I think I'm getting 90 or 80 or so. A bit worse. I don't check it there. I don't check it.
Yeah. Yeah.
But I should check it with my condition. If I see the doctor every 3 months. So I should say, try to get in the 180 over 120
I mean,
range.
yeah, 120 over 80 or lower,
Okay, so I
where you
should,
should be.
so I have the meter at home, 2 meters, so I should just check it once in a while. Don't be afraid to check it. Write it down.
Positioning, right? Don't watch the news. Don't talk about politics.
Right, yeah, don't have no anxiety or something like that. Right. So if it's higher than 130, next time I go to any doctors, explain it that's higher than I normal.
So here's what I would recommend is a self-measured blood pressure log, okay? So if you check it and it's higher than 130 over 80, write down whatever you get. And then
Right.
check it several more times using good technique, using a valid.
Right, yeah, like I saw it. No,
Go to see your provider. Here are my 15 blood pressure readings from the past 2 weeks.
right, yeah.
What are we gonna do?
I know I got a meter for the diabetes. It watches tracks it that way, but I'll just start doing with the pressure. This guy's next.
You brought it.
We had some other questions.
I do have a question.
Sure.
So for somebody who, and this is really for me. Not a clinical, right, not a fake one, but you know, for my whole life, I was a lot heavier, so my blood pressure was always high, but my none of my other risk factors were a concern, so to speak, to my primary care. Get a physical every year, everything comes back great. I lose 60 pounds. You know, one was per diet, right? Probably 30 pounds was diet and healthier living. The other 30 pounds was because I had Lyme disease, and I guess the 30 pounds of fluid came off of me, kind of thing. So that helped with it. So if you would look over my chart, my blood pressure, I would say I have high blood pressure, you know, would go high. But now my blood pressure is normal, right? But I know I'm an excitable person, and throughout the day, I'm sure that blood pressure goes up. So, you know, I'm 52. Well, I drive all over Pennsylvania, but I mean, for somebody, if you're borderline high, you know, let's say you're 125 over, 78, whatever, no other risk factors, right? From what I'm reading on that screen, it should be up under 120 over 80. No matter what other risk factors you have, that's a standalone number.
That's where we're going. That's where we should be taking you if we're taking good care of you. But it also stands to reason, right? You said you're an excitable person. Things happen. This hypothetical.
Not in a bad way, I'm just excitable. Yeah.
So it raises the question, what are your average blood pressures out of the office?
That's right.
Right? Are you living in the high range or the low range? So your doctor might suggest a self-measured blood pressure log. Your doctor might suggest a 24-hour blood pressure monitor. We didn't get into that, but that would be another good way to assess what's
And
going on for you.
This is selfish, and I'm going to give it to my primary care doctor. But at first I was like, I don't want to take anything. I'd rather not change my lifestyle or whatever. And the one big thing that really did change everything was breathing. Was unbelievable. I mean, it really changed. It really did drop my numbers dramatically. But it's also, being that I'm excitable, it's like a false number because I can go into the doctor's breathe and stuff and get it at least remotely close to where it should be or whatever.
And that's part of why that prepare phase is so important, right? Have the patient sit quietly, calmly, 3 to 5 minutes. Do good deep breaths.
Yeah,
right?
that did help.
Relax, cool your jets.
That's it.
Yeah,
May I add to that, Dr. Anderson?
please. But
So-
only if you use the bouncy cube.
I have the bouncy cube. Dr. Bali, we are all colleagues, Dr. Shang, Dr. Anderson, and myself. I'm the Northeast guy. So, I think you raise a good point, and I think that's a great point to discuss as an educational tool to acknowledge that blood pressure is indeed a variable. All day long, your blood pressure changes, and it has to. You know, when I'm rushing down the road to navigate through traffic, my blood pressure does not go higher, then I may not have the alertness to navigate through Scranton traffic. When I'm grabbing grocery bags from my car back into the house, if my blood pressure did not surge, my muscles, which are demanding that increased perfusion, require that higher blood pressure. So those are not states of disease. A state of disease, what we call hypertension, is a blood pressure that is higher than ideal when you don't have physical or mental burdens. And this is exactly why Dr. Anderson was emphasizing that preparation is so crucial. You've got to be correctly postured. You have to have an empty bladder, feet flat on the ground, elbow resting on a flat table, no mental stimulation, radio and television should be switched off, no conversations, etc. And that's when you check your blood pressure. So you have to try and make a conscious effort to take out all the excitability out of the equation, because that is completely natural to have that surge in blood pressure as the day progresses.
Thank you.
Are you a doctor?
Yes, sir.
I thought you
These are my partners here, and they're, yeah.
were. He answered a lot of my questions right there. I didn't realize pressure goes up and down when you're walking or doing exercise. When we do exercise, a lot of times I push myself on the treadmill. And is that good to do? Is that good to do, doctor? Push yourself on exercise.
Absolutely. So why do we encourage patients to do exercise? It's not necessarily for weight loss. The primary aspect that we're trying to work on is to improve your cardiovascular health.
Right, that's what I thought.
So pushing yourself is the cheapest stress test that you can do at home.
Yeah,
Keeps your heart healthy. In fact, it helps you catch something which is amiss. If you're trying to push yourself to your limits, and if you start noticing that my exercise tolerance is declining, for example, then that might be proof that perhaps you need to make a phone call to your primary care doctor. That I could do 5 miles without breaking a sweat, and now I'm having this strange uneasiness in my chest.
that's good to know, because a lot of times I go on the treadmill, I want to go faster and work up a sweat, and I don't get no pain, so I'm doing good then.
I think so.
Okay, that's good to know.
Now, there are exceptions to every situation, of course. If you've recently had an acute event involving your heart, your cardiologist might dictate certain limitations to how much you can and cannot do. So discuss your specific health circumstances, of course, with your doctors.
Yeah.
And the other takeaway from that is we all need to move more wherever we are in life, whatever that means for each individual person, right? For you, it might mean getting on the treadmill. For me, it might mean, I got to walk more than 2,000 steps a day. How about 3? Right? Or whatever it means. It's individual. And it changes. Yes, ma'am.
So I know that we're talking about positioning and all of that, and that's thinking about us doing self-monitoring of blood pressure. But like when I go to the doctor, anywhere,
Mhm.
I don't know. I can't remember the last time that all those things, I do remember going to one place and they were very, like, we need to have your arm here and you need to have both feet on the ground. And I remember that conversation, but that is unusual. So is there like an effort to train physicians and
Okay, here's a good.
other people?
Here you go, doctor.
Yeah, thank you. Yeah, that's a great point. And whenever us docs see other doctors and go, we all comment on the same thing too. It's kind of a pervasive problem to get your blood pressure measured accurately. So certainly there's a lot of programs to try to improve that process. But as you can imagine, people are busy. It's hard to get people to do the right thing. The patients may not even want it sometimes too. People tend to be optimists and they don't want to say your blood pressure is really high. It's like, oh, let's recheck it. And then maybe they don't check it quite as accurately as they could. And, you know, you should, if you are using a manual blood pressure device, you're supposed to basically listen to hear where the sound is first and then deflate the cuff and then pump it back up to like 20 above that and then release it really slowly. That doesn't really, I don't remember the last time I've gone to any nurse rooming and had that happen outside of like a research study. So, and that's part of the reason for you emphasizing the automated devices. But I think for patients, I mean, what I've heard from patients that I've worked with and as patient partners is that, you know, you just have to advocate for yourself. And if you know how to measure your blood pressure yourself and you do all the things you're supposed to and you bring it in, I mean, that's, you know, and hopefully your doctor accepts them. Be like, okay, I see your blood pressure is much different at home. The other thing you can do is just bring your blood pressure device to the clinic if they're not sure if it's accurate or not, and they can check it right there with you. So that's probably the best way to address it. It's kind of hard to get, you know, people to do the right thing, but you should call it out.
And we are working as a health system right now, and we have introduced programs across primary care and specialty clinics to really work with staff at using automated devices and using proper technique for preparing the patient to check blood pressure. So it's a all hands on deck effort right now. And it
Yeah.
should be.
Yeah, and one thing we were trying to emphasize is if it is high initially, to at least then do the right thing. And, you know, okay, we're going to have you rest for, 5 minutes or 3 minutes, and then we'll check it twice after we just kind of let you relax. So hopefully they have enough time to do that in the clinic visit. And I certainly would ask that if they were going to change medications, that you have a good understanding what the blood pressure is.
Okay, the last question. I'm 74 and I'm concerned about Alzheimer's. So my mother had it and my sister had dementia. And I don't want to have it, but it seems like if high blood pressure leads into the disease, doesn't it? Out of control.
Uncontrolled blood pressure is a risk factor.
Okay, so keep my pressure down and probably live good. Here's next, anybody else?
I'll say two things. It's more just to go along with what's been said. I actually do take my blood pressure at home, and I get a reading that's, on my machine, 140 or less, and I'm in the normal range. So like I do my best to get under that 140, and I do. But when I get a higher reading, and it's just only a couple seconds, I'll do that 10 breaths in and out nice and slow. And I can get that 140 or so reading, even like, 138, and get myself into like a 123 over like 78. And I do write that down and I do take it to my doctor. But I just saw him probably like 3 weeks ago, and I thought I was doing pretty good at like, he said, well, what's your average? I said, even though I had it, you've said it before. Anyway, 135 over, let me pick an accurate number, like 135 over like 85, I said. He said, well, that's good. But he said, we really want to get it down to the 120 over 80 or less. And I'm thinking, well, jeepers, like the harder I try, the more you keep raising the bar, Yeah, but now that's going right in.
You brought your averages, you have it.
Yeah,
And
and
here's the next step.
I'm on Thomas Sarton, which is the next generation. And, we went from like 80, he had me down to 20 because we were talking, and I walk a little, well, I walk quite a bit actually. But anyway, so he, to get that 135 over what I say, 85, he went from 20 to 40. And I just started that in the last 2 weeks. And I'm seeing that come down to those. I've had a couple 117s over like 68s or so. And I'm like, well, geez, am I still here? But the point is, no, that's the right direction. And actually, he wants feedback from me. We do the portal thing, and believe me, I don't go on there a lot. but I'm going to because, you know, I mean, he really right on target with what, everything you just talked about, quite
Yeah.
frankly. So,
Just
Yeah.
as a provider who works with a lot of patients for self-measured blood pressure,
Yeah.
please let me know what your blood pressures are doing at home.
yeah,
But
I bring it in.
batch it. Please bring in 12 or 15. Please don't call me on reach out on the portal and say, my blood pressure today was 135/85.
I do 2 weeks at a time, but yeah.
It's very sweet. I care,
Yeah.
but I can't do a lot for you with just one reading,
Yeah.
right? So we need batches. We need to know what the ballpark is, just like we do with blood sugars, just like you would with your bank account. You need to, you have a ballpark sense where.
But
things
you
should
said
be.
set the stage, and when you were saying that, I'm thinking like, yeah, and it gets me back, and it's just that 10 in, 10 out, and I do try to do the diet stuff, but I will have a couple of beers and wings sometimes, but not every day, I'm still here, I'm gonna have a couple of things. Oh, no, anyway, I just wanted to say like, thank you, because that's exactly what my guy recently told me, the very things you just talked about.
Good. I'm glad to hear it. I'm glad to hear it.
Anybody else there?
Anybody else care for the bouncy, I don't know what this is called.
The box.
The box, the catch box.
Thank you.
Question?
Yes, thank you to Brian for putting a question in the chat. So this is a comment or event with a question. I have a family member, 80-year-old male, trucker's diet for 30 plus years, who had a quadruple bypass. If he's been educated on diet, his behavior change, measuring salt intake, is pretty much non-existent. Question, how does even the best doctor, pharmacist who see their patients 2 to 4 times a year compete with hundreds of ads for high salt food on TV, driving them, or social media? More broadly, what do the Scandinavian and other EU countries with so much better lifespans, what are they doing better than us? Is it better use of dietitians, better diet, better preventive medicine, or better medical treatment of hypertension compared to US?
Oh, wow. What an amazing set of questions.
You want me to go back through them?
I think we got Dr. Chang. Here comes the, I'm never gonna figure out what this is called. I can throw it.
Okay. Yeah, I mean, I think that kind of packs it all into, that kind of solves hypertension right there. But I mean, what they're doing better is their whole lifestyle, right? I mean, it's the food environment, it's people's social norms. I mean, yeah, there's only so much dietary counseling you can give to some patients, unfortunately. I mean, it's just about what they're used to and how things are structured. But it doesn't mean it's hopeless, though. I mean, that's also, unfortunately, that's why we have medications, too, because if people don't want to change, and obviously people do need medications regardless of lifestyle modifications, but if there's, I think you can frame it in different ways to patients, because sometimes patients don't want to take medications or as many, and you might be able to use that to motivate them to make some drastic changes. But if they're not going to go from the trucker's diet because they really, really like it to something different, you're kind of out of luck there. I think the other part of it that's sort of we've mentioned a few times is the obesity part, because I mean that's a huge driver, and it's also tied to all the other stuff we're talking about. So if you have somebody who's significantly overweight and then they lose 50, 60 pounds, I mean, you can cure hypertension pretty often in those cases. So we have, especially now that there's more powerful treatment options along with lifestyle that are tied together. We're seeing some patients that, they had resistant hypertension. Nothing was really working. I mean, it was working somewhat, but never enough. And then we get them able to lose a significant amount of weight, and then finally their blood pressure is under control, or they're even off of blood pressure medication. So yeah, a great question.
Answer too.
Anyone else?
Here's a question, last one.
Bouncy ball.
Okay, I go to my internist every 3 months, and she does the pressure. It never talks about the pressure, master. It's okay, it's okay. Should I ask her what the pressure was?
Yeah,
I gotta take a reading average and show her this time, as she says.
average. I mean, take the averages of what you're getting at home. Ask what the average is in the office past couple visits.
Okay,
Do
and
they
then,
line up?
and
Do they
then,
not line up?
is it possible I could get weed off some, if my pressure goes down, I can weed off some of these other pills? Your doctor?
Well, if you have significant, other cardiometabolic or kidney issues, some of those medications are not just there to lower your blood sugar or lower your blood pressure. Some of them are also independent of that shown to reduce your risk of heart events or kidney events. So it kind of depends. There are some drugs that people are on that you can certainly wean down if you get things under control. Like insulin is great, but it's not one of our top line diabetes medications anymore. It's kind of it's one of the things that people need still. But if you can control some of those other things and people lose weight, for example, then you can start weaning down some of those other medications that don't really have any additional cardiovascular stroke prevention benefits. So I don't know about your case, but yeah.
Because it's a goal you could try.
Right, exactly. There's a goal you can try, but you don't want to just stop the medications because they might have some other benefits to them.
Work at it.
Yeah.
You could work with the doctors, you say,
Yeah,
and
exactly.
they get a good feel of it.
Talk through, why am I on this? Do I need to be on this? How's it
Exactly.
helping me?
Yeah. I just say, they say, well, I go to a pill, just get the pill.
You could do that too. But it's helpful to ask, right? If you're wondering.
Well, now I know work with it. Next time I see them, I'll ask more questions.
Sounds-
Oh, should I get a doctor that has just for help for pressure? Is there a doctor just for high blood pressure? Or your internist visit?
Dr. Bali, would you like to answer that one?
Sure.
So the three of us, we are basically hypertension aficionados. But we are also kidney doctors by training. So the internist is definitely the first responder when it comes to the diagnosis and management of hypertension.
Right.
But hypertension affects so many different systems. I can't say that a cardiologist, a heart doctor, would not be engaged in someone's blood pressure if they were seeing you in the office. Similarly, if you had some kidney concerns, a nephrologist would also be intervening with regard to your blood pressure. When it comes to specialized cases, however, I think nephrologists, kidney doctors are best suited to deal with those complex cases of hypertension. And I think that's a very good segue for us to quickly touch upon the fact that the three of us, we are directors of our AHA certified hypertension, comprehensive hypertension centers, one each in Wilkes-Barre, State College, and Danville. So Geisinger has essentially entered into the next era of hypertension care by adhering to certain practices and policies so that we can deliver hypertension care to our more complex patients, as well as try and change our approach to hypertension as a program, not at an individual basis, but through algorithms and protocols and education, as you're doing today.
Is your office in Wilkes-Barre?
Yes.
You have required?
In Texas.
Wow. Bravo.
I know.
Okay, call up Geisinger or get an appointment, right?
Sure.
Okay, here's a man that's gonna help. Thank you. Paul. I needed something like that. I was going through life, I was all confused.
No, but I think this highlights the fact that more engagement is always beneficial. And believe it or not, your primary care doctor would love to have this kind of conversation with you. Sometimes the constraints of time don't allow these conversations, but these are exactly the things that they are worried about. So you'll find that you have a lot more to discuss, a lot more common enemies than you might realize. And And on that question, like you were asking about what is the right number of medications? I basically ask my patients, well, what is the right number of fire trucks to address a house fire? Well, the number of trucks it takes to put the fire out, right? Once the fire starts to die down, we can always send some home.
I think by going through an internist, they're very good, but sometimes you need a specialist to oversee everything, right?
Not necessarily. I think the bulk of cases are pretty straightforward, where optimizing medications and emphasizing on what you have control over, diet and lifestyle, can solve a great deal of problems. There are certain cases where it might fall outside the purview of an internist, and we are here to help for those cases.
Yeah, I go to a kidney doctor, I go to a heart doctor, and I go to internist, and I go to her RA doctor. I go to a lot of doctors. And I just take the pills what they say. Maybe I'm taking too many pills. You know, possible, right?
It's possible, but again, individual cases have to be looked at individually. And I think it's best to look at you separately.
Okay.
I don't want to be discussing your health in a public forum.
I just want to say one thing. So it is really impressive to see, people from the community come out and come to these events and to learn about everything. I really do think it's remarkable. And I will be very honest, I work for a pharmaceutical company. Doesn't matter who, what I have or anything like that, but it is absolutely remarkable. And this is from a patient, from me being outside of that role, but it is so impressive to me to see physicians knowing, I bring up what I do for a living, knowing your schedules, the pressure that's on you guys and the things that you have to watch, to see you come out and talk to the community, to bring your children out is absolutely remarkable. Absolutely
Yeah,
remarkable.
thank you for coming, guys.
It's true.
Are we really going to end without somebody on this side of the room chiming in? It's not obvious. I just want to make sure nobody's missed their chance. Anything? Oh, come on.
We're taking it back.
This is, so if someone's blood pressure was always in the lower range, like maybe their top number was 105 or something usually, and then it's raising up, I guess increasing over years, and then it still might be, their average is still less than 120, but there's been like a 15, is that harmful, or is it that absolute number that is kind of determining the risk for some kind of?
Great question.
Well, an interesting thing is that if you look at some societies where they don't have any salt, which probably don't really exist too much anymore, but in the rainforest, some of those people, their blood pressure doesn't go up with age, and they think it's because of salt, basically, amongst all the other environmental stuff going on. But so yeah, there's a natural tendency for blood pressure to increase with age. Unfortunately, that's why most people, as you get older, get hypertension. So it's probably not really that much of a concern if you're starting off low, because you have a lot of room to go, I guess. But you could still, that person could still develop hypertension theoretically. But yeah, the absolute risk is still going to be pretty low if it's still, the other thing that we didn't really mention is sometimes like in the postmenopausal period too, we're seeing there's a lot more data about blood pressure going up for women and maybe not being treated as aggressively sometimes too. So I think there's a lot of stuff going on there too, which is interesting.
And February is Women's Heart Month. So I'm wearing red. So, yeah, so time to double down. We have a
I just want to know how much stress and anxiety and maybe lifestyle affects your blood pressure.
Yeah, all of it. The stress and anxiety certainly can affect your blood pressure. Look, I think the question underneath that is, how are you handling it, right? Are you bottling it up or becoming a type A person, or are you finding outlets for it? Are you exercising? Are you getting good sleep? Are you taking steps to relax? For example, not you personally, but this hypothetical patient.
Well, I'm on medication for anxiety and depression.
Super common.
What else?
Are you still on blood pressure medication?
No, I went off my blood pressure medication because I always had very low blood pressure medication. And then my doctor put me on medicine that really, like I was getting dizzy and falling and well, I don't want to.
Blood pressure bottomed out.
Yeah, that's why the close follow-up is so important, right? Because maybe instead of blood pressure medicine, we needed a home blood pressure log to see what you were doing at.
Well,
Was it
you know,
stress about being in the office? I mean, there's lots of possibilities.
she did tell me to take my blood pressure at home, but I think I got more aggravated and like that made my blood pressure go up higher. And then if I saw that it was high, that would make me even more anxious. Yeah.
Yeah.
And I did see a therapist, but the medication and therapy just doesn't seem to be working. And I did go off the high blood pressure medication, but I'm wondering if I should be off it.
It sounds like something that you might want to circle back to your family doc and find out.
I will be looking for another one.
Okay. Yeah. You have to have a working relationship. You have to have that trust.
Thank you.
Of course.
Thank you, everybody. One final round of applause, like a volleyball, for Dr. Anderson, Dr. Chang, and Dr. Bali.